Hi, I'm Mel Akerman.
I'm Anne Woolfield.
And I'm Carla Pecoraro, and we're your hosts of the Uterine Sound podcast, bringing you up-to-date information in all things O&G. Now, we finished our discussion on torch infections, so today we're diving into a deceptively common but often misunderstood infection in pregnancy, Parvovirus B19. We're talking slap cheeks, school-aged kids, fetal anemia, and some seriously fascinating pathophysiology. So grab your coffee, because today's episode is one for the infectious disease nerds amongst us. Did you know that there has been an outbreak of parvovirus in Victoria recently? There's been an outbreak of parvovirus in dogs in Victoria in 2024, including a few deaths.
Interestingly, in 2024, an epidemic of human parvovirus infections was reported in Europe, which led to a public health alert. Another alert was made by the CDC in the United States. A clinical alert was issued in Australia stating that in Victoria in 2024, fetal medicine units have observed an increase in cases of fetal parvovirus infections, including those that received intrauterine transfusions and perinatal loss.
Do you know if an alert has been issued in Queensland?
Not at this stage, but given the outbreak in Victoria, it's good to stay alert.
Okay, let's start with the basics. So Parvovirus B19 is the virus responsible for fifth disease.
Hang on, if there's a fifth disease, what happened to first, second, third, and fourth disease?
So it's interesting that you asked that. So these names originated in the late 19th and early 20th centuries when pediatricians were trying to work out what childhood rash caused what illness. So first disease is actually also known as measles. Second disease is scarlet fever. Third disease is rubella. Fourth disease is Duke's disease, which apparently no one thinks exists anymore. And fifth disease is parvovirus. Interestingly, there's also a sixth disease, which is roseola infantum, otherwise known as human herpes virus. But anyway, back to fifth disease.
If you think back to any P's you've studied, fifth disease is also known as slapped cheek disease because of the typical erythematous facial rash. Parvovirus is a single-stranded DNA virus that preferentially replicates in rapidly dividing cells, like erythroblast precursors. This explains its role in fetal anemia. In women with a severe hemolytic disease, such as sickle cell disease or hereditary spherocytosis, it can precipitate an aplastic crisis. To be susceptible to parvovirus infection, individuals need to have an erythrocyte membrane P antigen, otherwise known as globicide. The virus binds to this antigen to infect the erythrocytes. Rare individuals lack this P antigen and are naturally immune to parvovirus. This unique consequence of parvovirus in pregnancy directly relates to the impact of the fetus. Unlike other congenital infections, which can cause fetal anomalies, a fetal parvovirus infection causes fetal anemia and the sequelae of this. This includes high drops, miscarriage, and stillbirth. Interestingly, another fetal complication is myocarditis.
And it's incredibly common. By adulthood, around 60% of women are already immune, leaving 40% still susceptible. We see a seroconversion rate of 1 to 2% annually, but this can spike to over 10% during outbreaks, which are usually every few years. It's the most common infection that causes non-immune high drops in autopsied fetuses.
Transmission is via respiratory droplets or hand-to-mouth contact. Now, I know we mentioned dogs earlier, but the parvovirus in dogs is different to that in humans. We can only get it from other humans. The population groups that are most susceptible to infection are those living with school-aged children and daycare workers. Interestingly, teachers are not at higher risk, likely due to more limited contact.
So how does parvovirus present?
Around 20 to 30% are completely asymptomatic. The rest may get a flu-like prodrome with fever, malaise, symmetrical arthralgias, lymphadenopathy, and some may have ERTI symptoms, followed by the classic slapped cheek rash, which can spread to the trunk and limbs. Adults often have milder rashes.
In immunocompetent people, by the time the rash appears, they're no longer infectious. I guess this is important for exposure and isolation advice. Once the rash appears, there's no point in isolating them. So let's go through a case. Meet Lucy. Lucy's a 31-year-old G2P1 who's 16 weeks pregnant. She's a 5-year-old son who's in prep. Her son has been off school for a couple of days with a flu-like illness. He then develops the classic slap cheek appearance. Lucy takes her son to the GP and he's diagnosed with fifth disease. What is the risk that Lucy will get infected after this exposure?
Well, as we mentioned, 40% of women of childbearing age are susceptible to parvovirus infection. That is, 60% will be immune. The risk of infection after an exposure depends on the type of exposure. The ACIP guidelines use 3 different exposures. For Lucy, because her exposure is at home, the risk of infection is up to 50%. But since she might be immune, the overall risk of infection is up to 20%. The second exposure is at school or childcare. In this case, the risk of infection is 20 to 30%, with an overall risk of exposed of 8 to 12%. And the third is exposure in the community. The risk of infection if susceptible with this exposure is up to 20%, with an overall risk of infection of up to 8%.
Lucy's GP has phoned the Maternity Assessment Centre registrar for some advice for Lucy, given her exposure to parvovirus. So first, I'd ask a bit more about Lucy's history. Has she been unwell at all recently? Particularly asking about symptoms of a rash and arthropathy. I'd also ask about her pregnancy to date. Has she had a first trimester ultrasound and aneuploidy screening? We want to know if she's had any complications with her last pregnancy. I'd also ask routine questions regarding her past medical and surgical history, medications, allergies, and social history. Next, I'd advise Lucy's GP that her son is no longer infectious, so Lucy doesn't need to try and isolate from him. We need to know if Lucy is susceptible to infection, and so we've requested that her GP arrange parvovirus serology for IgG and IgM.
All right, it's serology time. Hopefully, the last time in a while. The good news is that parvovirus serology is actually pretty straightforward. So let's break it down. If the IgG is positive and the IgM is negative, this means the patient is immune. Simple, no further testing needed. If both the IgG and IgM are positive, that suggests a recent infection, so that does require follow-up management. If both the IgG and IgM are negative, then the patient is susceptible. So in this case, we need to repeat the IgG in 2 to 4 weeks after the exposure or sooner if symptoms develop. Now, if the IgG is negative, but the IgM is positive, we do the same thing. Repeat the IgG in 2 to 4 weeks or if symptoms appear. When we repeat the serology, if the IgG is still negative, we assume the previous IgM was a false positive. The patient is still susceptible, but no further action is needed. If the IgG turns positive, i.e. the patient seroconverts, then we treat it as a recent infection and manage it accordingly. IgM antibodies take about 7 to 10 days post-infection to appear. They persist for 3 to 4 months and indicate a recent infection. IgG develops a few days later and gives lifelong immunity. You can also detect viral DNA on PCR, but it may linger for months or even years, so it's not a reliable marker of a recent infection. For Lucy, the indication for serological testing for parvovirus was an exposure. What are some other indications?
Well, first I wanted to say that routine screening for parvovirus is not recommended. Indications for parvovirus serology include exposure to a known case of parvovirus, symptoms of an infection with parvo, especially symptoms such as a rash and polyarthralgia, and ultrasound features of fetal anemia like polyhydramnios, ascites, pleural or pericardial effusions, and hydrops.
Okay, Lucy's serology has returned as parvovirus IgG and IgM positive. This is a confirmed recent infection. The next step will be to see if there is a confirmed fetal infection. Vertical transmission occurs in 30 to 50% of maternal infections, and 85% of fetal infections develop within 10 weeks. So the average is about 6 to 7 weeks after a maternal infection. The critical window is 13 to 16 weeks gestation, when fetal hepatic hematopoiesis is at its peak. This is when the fetus is most vulnerable to the anemia that parvovirus can cause. Notably, infections in the first 4 weeks of pregnancy don't result in transmission.
But let's be clear, not all infected fetuses do poorly. Only about 1% develop hydrops, and many resolve spontaneously. The rate of fetal loss is between 8 to 17% before 20 weeks, dropping to 2 to 6% beyond 20 weeks. Unlike other perinatal infections, we do not need to confirm a fetal infection before we plan our ongoing management. After a confirmed recent maternal infection before 20 weeks gestation, serial ultrasound examinations are organised to assess for the development of fetal anaemia. For Lucy, we should arrange an ultrasound every 1 to 2 weeks for 12 weeks, specifically looking for signs of fetal anaemia. The Doppler we look at for this is the middle cerebral artery peak systolic velocity, otherwise known as MCA-PSV, at its most reliable after 18 weeks gestation. If there is no fetal abnormality after 30 weeks, then no further follow-up is required. What happens if there is evidence of the development of fetal anemia?
If hydrops or anemia is detected or suspected based on ultrasound, the next step is to refer to maternal fetal medicine. MFM would usually confirm on ultrasound and consider fetal blood sampling via cortocentesis to assess for anemia and thrombocytopenia. If anemia or thrombocytopenia is confirmed and reaches a critical level, an intrauterine transfusion is then considered. The good news is that most babies only need one transfusion because erythropoiesis recovers as the infection clears. Generally speaking, termination isn't recommended because there is a low risk of fetal damage and parvovirus is not associated with teratogenicity. The overall long-term outcomes for babies that were infected by an intrauterine infection with parvovirus are very good.
The prognosis with transfusion is excellent, resulting in a 94% resolution of hydrops and fetal anemia within 6 to 12 weeks. With treatment, the overall mortality drops to under 10%. Without treatment, however, hydropic fetuses have a 30% mortality rate.
I like to remember some facts with a 30-30-30 rule. For those fetuses that develop hydrops, there is approximately a 30% mortality without intrauterine transfusion, there's a 30% spontaneous resolution of hydrops, and a 30% resolution after an intrauterine transfusion. So, how do we prevent parvo?
Unfortunately, there's no vaccine, and antivirals don't work. And because infectivity peaks before symptoms, isolation of infected children isn't effective. We don't recommend excluding pregnant women from work, even in high exposure settings like schools or daycares.
Ongoing management during pregnancy and postnatally involves ongoing monitoring for fetal and neonatal anemia. Those neonates that did have hydrops, which resolved in utero, should be monitored for anemia. Now, a little short one for us. I think that's it for parvo. So shall we do a summary?
Absolutely. So Parvovirus B19 is a DNA virus that infects rapidly proliferating cells. In pregnancy, it predominantly infects the hemopoietic cells of babies. The consequences of parvovirus in pregnancy include hydrops, miscarriage, and stillbirth. Interestingly, another fetal complication is myocarditis. Parvovirus is very common, and by adulthood, around 60% of women are already immune. There is a seroconversion rate of 1 to 2% annually, and parvo is the most common infection that causes non-immune hydrops in autopsied babies.
Transmission is via respiratory droplets or hand-to-mouth contact. The population groups that are most susceptible to infection are those living with school-aged children and daycare workers. That said, the risk of infection varies. About 5% for casual contact, 20 to 30% for intense, prolonged work exposure, for example, teachers, and up to 50% for frequent close contacts, like having an infected child at home.
Those with a parvovirus infection may be completely asymptomatic. The rest may get a flu-like prodrome, including fever, malaise, symmetrical arthralgias, lymphadenopathy, and some may have URTI symptoms. The flu-like illness is followed by the classic slapped cheek appearance, which can then spread to the trunk and limbs.
Routine screening for parvovirus is not recommended. Indications for parvovirus serology include exposure to a known case of parvovirus, symptoms of infection with parvo, especially symptoms such as a rash or polyarthralgia, and ultrasound features of fetal anemia like an elevated MCA-PSV, polyhydramnios, ascites, pleural or pericardial effusions, and hydrops. To summarize the interpretation of serology, IgG positive and IgM negative equals immune, IgG negative and IgM negative equals susceptible, and you should repeat testing in 2 to 4 weeks. IgG negative and IgM positive is either a false positive or a recent infection, and you should repeat the IgG in 2 to 4 weeks. And IgG positive with positive IgM means a recent infection.
Vertical transmission occurs in 30 to 50% of maternal infections, and 85% of fetal infections develop within 10 weeks. The critical window is at the 13 to 16 week mark when fetal hepatic hematopoiesis is at its peak. This is when the fetus is most vulnerable to the anemia that parvovirus can cause. But only about 1% develop hydrops. After a confirmed recent maternal infection before 20 weeks, serial ultrasound examinations are organised to assess for the development of fetal anemia. An ultrasound should be done every 1 to 2 weeks for 12 weeks, specifically looking for signs of fetal anemia, including an MCA-PSV. If there's no fetal anomaly after 30 weeks, then no further follow-up is required.
Amniocentesis to confirm an infection is not recommended. If hydrops or anemia is detected or suspected based on ultrasound, the next step is to refer to maternal fetal medicine and to consider fetal blood sampling via cortocentesis. This assesses for anemia and thrombocytopenia. If it reaches a critical level, an intrauterine transfusion is then considered. Most fetuses only require one transfusion because erythropoiesis recovers as the infection clears. For those fetuses that develop hydrops, there is an approximately 30% mortality without an intrauterine transfusion. There's a 30% spontaneous resolution of hydrops and a 30% resolution after an intrauterine transfusion.
Unfortunately, there's no treatment to prevent fetal infection or damage. Parvovirus in pregnancy is one of those conditions that straddles infectious diseases, fetal medicine, and public health.
So the key takeaways are know the timing, monitor closely if infected, and don't overreact. Most babies do well, even with hydrops, especially if it's caught early and treated with an intrauterine transfusion.
And that wraps up today's episode of the Uterine Sound podcast. Thank you for listening. You'll find our summary slides on Instagram later in the week. Check out our website, www.theuterinesound.com. Email us at theuterinesound@gmail.com and find us on socials at The Uterine Sound.